Well, ladies and gentlemen and everyone, welcome to the launch of the Sepsis Clinical Care Standard. And this is the first Australian national standard for the care of sepsis. And it's being launched today by the Australian Commission on Quality and Safety in Healthcare. My name's Julie McCrossan, and it's my genuine pleasure to be your host today. Look, today we're broadcasting on Aboriginal land. It's the land of the Gadigal people of the Eora Nation, and we are paying our respects to elders past, present and emerging. Our purpose today is to raise awareness about this new sepsis clinical care standard and new educational resources that we have for you. But I think our fundamental goal is to save lives and to reduce serious complications from sepsis. And we also want to improve the long-term care of people who have ongoing complications after sepsis. And just before we begin, I really want to thank you. Many of you have already sent in your stories about sepsis when you registered for this webinar. You've shared challenges you've faced in diagnosing sepsis, and we've also had families talking to us about the experience of sepsis with family members, or indeed patients themselves have discussed their experiences. And we're going to try and make a real difference and improvement to the care of sepsis in this country. Well, shortly I'm going to introduce you to clinicians who are working across Australia to improve sepsis care. But first, it's my great pleasure to welcome Dr. Carolyn Hullock. She's an emergency physician at Hunter New England Health in New South Wales and a clinical director with the Australian Commission on Quality and Safety in Healthcare. And Carolyn is going to give us an introduction to the Sepsis Clinical Care Standard.
Thanks, Julie. I'm also on the Awabakal land, and I would also like to acknowledge that there are worse outcomes for Aboriginal and Torres Strait Islander people in sepsis, and it's an important issue that we all need to reflect on. So sepsis is life-threatening, time-critical and complex. Sepsis is a life-threatening condition that arises when the body's response to an infection damages its own tissues and organs. It's preventable, but when it occurs, it's a medical emergency, often with rapid deterioration. Time-critical treatment is required to prevent multiple organ failure, lifelong disability and death. But sepsis is complex. It's a clinical diagnosis and signs are not specific. There's no specific test that we can do that says this person has sepsis. We still need clinicians like doctors and nurses thinking about sepsis as a complex condition. Delays in diagnosis and treatment can lead to tragic results that change the lives of patients and have a lasting impact on the healthcare system teams. This is a story that comes from the Northern Territory. The community had suffered a tragic fatality when signs of sepsis were not recognised in a teenage girl until she was in an advanced state of deterioration. And I'd like to suggest that many hospitals across Australia also will have similar stories that really impact on the staff for many years. It's a tragic loss of life, a tragic loss for that child's family, and also in a different way, very shocking and hard for the team who were involved in her care. But the team really picked themselves up after this tragedy, and the tragedy was a trigger for some of them to really reflect on how they could improve care of sepsis at their regional hospital. It involved a lot of time with listening to the child's family, answering their questions and listening to their perspective on the experience and how things could have been done better. It involved a really rigorous review and a reflection for the team. It resulted with some really impactful changes in the hospital processes and also in the way that team members are encouraged to share their challenges and even their failures and learn from each other. Sepsis takes a toll across Australia with significant numbers. In 2017, there were more than 55,000 people with sepsis in Australia. But even more tragic, there were 8,702 people who died. The ongoing impacts are significant. Up to 50% of survivors experience physical, psychological, or cognitive impacts after discharge. This has been called post-sepsis syndrome, and we've talked about it quite a bit over the last 2 years with post-COVID syndrome. In children, cognitive and neurodevelopmental impacts have also been seen. Around 20% of adults were readmitted for sepsis within the next year, with many more presenting for many other reasons related to complications of their sepsis. But there's also a financial impact. The direct cost to the healthcare system is over $700 million a year. The estimates put the indirect costs at something in excess of $4 billion, which is hard to even comprehend. This takes into account the ongoing impacts on survivors who are living with disability and impairment, and those survivors and their families, and also the families of those who lost loved ones to sepsis. It can be really hard for them in being able to return to work, and often they've got carer responsibilities that they didn't have before. Sepsis disproportionately affects different populations across Australia. The very young, babies and children, the very old, particularly people living in aged care facilities, Aboriginal and Torres Strait Islander people. Other high-risk groups that we also think about are people who have had cancer, those on chemotherapy, and people who are immunocompromised. So we've developed the Sepsis Clinical Care Standard. The Sepsis Clinical Care Standard was developed to address the national clinical guidance to support improvements in the delivery of sepsis care in healthcare systems. While some states and territories have well-developed sepsis pathways, like the state I work in New South Wales, others do not as yet. And it really responds to the fact that recognising and managing sepsis is complex. Those situations can be difficult, and honestly, if sepsis management was easy, we wouldn't need a clinical care standard. The clinical care standard is one part of the National Sepsis Program, which aims to improve early recognition, treatment, outcomes, and post-discharge support for people at risk or diagnosed with sepsis in Australia. The George Institute have been really important partners for the Commission to develop and implement the work of the National Sepsis Program. And we've also been supported in our development process by a number of other organisations who've endorsed the final standard. As you can imagine, these negotiations have been quite intense over quite a long period of time, particularly with some of our states and territories. So we're really happy to have got here in the end. Thank you, everyone. We have 7 quality statements. It's important to remember that the clinical care standards are high-level guidance, not the detailed everyday guidance that we need for management of sepsis. But we thought that these were the really important 7 statements that we needed in order to ensure that when people present to the emergency department with signs and symptoms of sepsis, that we can recognise it early, but also that they receive coordinated best practice care so that the risk of death or ongoing morbidity is reduced. So the first 3 statements are around early recognition and rapid treatment of sepsis. Could it be sepsis? Has this person got sepsis? Have we thought about it? Then once we've decided that they do have sepsis, we need really clear systems in place to manage the time-critical management of sepsis. And it's also time-critical antimicrobials with antibiotics within 60 minutes from signs of infection-related organ dysfunction. As you can imagine, if we don't have those systems in place, it's very difficult to give antibiotics within 60 minutes. But also we want to make sure that the antimicrobials are used judiciously, and that at the end of 48 hours we've reviewed those antimicrobials and we're making sure that they're the right ones for the patient. The second part of the 7 standards is about the patient journey through the hospital. Has the person got coordinated and patient-centred care? And there were 3 important things that we thought were required for the good management of sepsis. So the first was around the multidisciplinary coordination of care in hospital, having someone who was designated across the hospital to work with the patients and their families, but also with the teams to ensure all the sepsis systems are in place. The second was around care and education of patients and families. And one of our consumers in our group talked about the fact that she didn't actually realise she had sepsis until she read it on a discharge summary, and that we also needed to be clear in transitions of care and communication and make sure that we include the patient and the family as often as we can. The last part is about care after hospital. Again, many of the survivors of sepsis have told us about post-sepsis syndrome, and that they may have spent months in hospital and then they're going home to a general practitioner or the community system that doesn't necessarily know much about sepsis. So we've thought a lot and talked a lot about how we can actually put systems in place to make sure that the community healthcare team and the GP and the patient and their family are also supported in sepsis. So could it be sepsis? It's a really powerful question. I think it recognises that sepsis is complex. in not only how it presents, but also and the diagnosis, but how we manage it as well. And that we need systems in place to manage this complexity. It's a powerful question for patients because it gives them the authority and the permission to say that we need rapid assessment and treatment. Asking, could it be sepsis, helps us to consider cognitive bias, which can lead to diagnostic error. It's about improving diagnosis. Patient escalation. I think there are two really strong themes throughout the standards that we haven't really talked about much before, but we've talked about in the development of the sepsis clinical pathway. And this was the patient escalation pathways. It's linked to the notion of encouraging, empowering everyone involved in a patient's care to think, could it be sepsis? Sadly, in coroner's cases and other investigations for adverse events related to deaths from sepsis, we see that patients and parental concern was not being recognised, with tragic results. It's important that our system and our own practice includes consumers, and that we as clinicians give permission for consumers to have a voice and that we listen. This is particularly important in the escalation of care. Sadly, many of the patient escalation systems have been named for children who have died from sepsis, like Ryan's Rule in Queensland. The other important thing we've worked on is cultural safety. With the sepsis clinical care standard, the Commission has for the first time included statements about cultural safety and equity. And I'm sure Lorraine will talk more about that later in the panels. But it's especially for Torres Strait and Aboriginal people, but also for others who have experienced barriers to access due to social factors, including culture, power differential, and institutional racism. Cultural safety represents a key philosophical shift towards providing a service that takes account people's unique needs. We need to be aware of our own culture and beliefs and expectations and consider how this can influence the way that we interact with people as health professionals. It's important to recognise as clinicians that we feel very comfortable in our clinical environment, and patients and families may not necessarily feel that way. It's good for us to feel comfortable at work, but we also need to be respectful and mindful that other people don't necessarily feel the same way. It's well recognised that our own beliefs and behaviours inevitably have an impact on the treatment that we deliver to our patients, especially if they come from a different culture to our own. Cultural safety describes a state where people are enabled. So you can find all this information on the Commission's website, along with an extensive range of resources. As well as the clinical care standard, there are supporting information for clinicians and the healthcare services. For consumers, there are information sheets and links to our resources. For the health system, we have information on lactate, on antimicrobial access and sepsis boxes, discharge plans, and templates for GPs, and also the role of the sepsis coordinator. In some ways, we rely on the health service to provide us with the systems in place in order for clinicians to do a good job. We've also got 3 health service case studies sharing the good work that they've been doing in relation to sepsis. One is a Code Sepsis alert that incorporates best practice for antimicrobial stewardship. A second is a sepsis program in one of our remote hospitals serving Aboriginal communities. And the third is an innovative family peer support program for child sepsis survivors run by Queensland Health and led by Paula Lister, who will be able to talk on this later. And there's more to come over the next few weeks and months and over the next year or two, so stay tuned. There's more work to be done. This is a beautiful slide. It reflects some of the faces of sepsis, and I'd really like to acknowledge the real people who have lived experience of sepsis, the survivors and the bereaved. During the development of this standard and other parts of the National Sepsis Program, we've been really fortunate to hear the voices of consumers about how they felt in the system and what sepsis meant to them. These are some of the faces of sepsis. The Australian Sepsis Network, as part of the George Institute, has worked really hard to bring these experiences into the public eye. And you can find these and many of their stories on the Australian Sepsis Network, and I'd encourage you to read them. I'd also personally like to acknowledge their resilience and their advocacy and thank them for coming and joining us in development of this sepsis program. It should be said that many people with sepsis receive excellent life-saving care, but from my own experience working in the ED, I know that things can go wrong. It's a tragedy for the family. It's also shocking for the staff who have been involved, and some of them never return to clinical practice. We all want patients to have good outcomes, None of us want to be in the position where something has gone wrong. And for that reason, that motivates me and all of us to stop and reflect on our preparation, our systems and our processes and treatment of sepsis. Could it be sepsis?
Well, Carolyn, thank you so much for that introduction to the sepsis standard, but also that deeply engaging expression of both the impact on clinicians of the challenge of diagnosing and treating sepsis in a timely way and the impact on families and people who experience sepsis themselves. It gives me a lot of pleasure now to welcome 3 clinicians who are working across Australia to improve sepsis care, and we will be looking particularly at issues for the very young, the very old, and for First Nations people. And it's welcome to Dr. Lorraine Anderson, Medical Director of the Kimberley Aboriginal Medical Services in Western Australia. And Lorraine is responsible, among other things, for 5 remote clinics. Welcome also to Professor Simon Finfer, AO, an intensivist at Royal North Shore Hospital in Sydney. Simon is also Professorial Fellow in Critical Care with the George Institute for Global Health, and he's also Chair of Critical Care in the School of Public Health at Imperial College London, and he's also Director of the Australian Sepsis Network. So welcome to Simon. And welcome also to Associate Professor Paula Lister, who was referred to by Carolyn. Paula is the Director of Paediatric Critical Care at Sunshine Coast University Hospital in Queensland and Medical Co-Chair of the Queensland Paediatric Sepsis Program. So welcome to you all, guys. I'm going to come to you first, Paula, because I think we really did feel, both with those images of people who've experienced sepsis and images of children who've either died or lost limbs, and also the emotion in Carolyn's voice about the challenge for clinicians. To lose a child to sepsis hurts everyone. Can you share with us the particular challenges you face in identifying the child with sepsis who comes in to accident and emergency? What are your challenges?
Well, look, childhood infections are common. And as an ED doctor, they will see lots of children with childhood infections. The problem is trying to pick the one child who's then going to deteriorate and go on and have sepsis. And it's a pretty rare event in comparison to how common infections are. So we sort of figured out it's for your average ED physician, it's 1 in 1,000 children who come to ED might end up with sepsis. So it's a pretty rare event. So we need to help our more junior staff to enable them to get more senior staff quickly involved in looking at patients who may be developing sepsis. And that's what this guidance is actually helping us to do. It's trying to make the business of sepsis and seeing sepsis and possibly recognising it, that question of could it be sepsis, everybody's job in the team.
This question, could it be sepsis? Why are we promoting that question nationally? What are you trying to groove into the frontal lobe of the clinical teams across Australia?
There's no single test and no single sign for sepsis. It's a constellation of signs. And we know that certainly in paediatrics, it's an experience of having seen it before that hones your skills in recognising it. So what we need to be doing is on the basis of clinical observations and histories that we get from parents, teaching our junior staff to think, could this be sepsis? And then when they're involving their senior clinicians, stopping that cognitive bias that Carolyn was talking about, saying the question, could this be sepsis, rather than, will you come and look at this child with bronchiolitis?
The call of the standard is to have in place a system in advance that's gone through a governance process and everybody agrees to. Can you tell us what you're doing in Queensland to get those sorts of systems in place, and what steps people can take to get the systems?
Well, in the front end of sepsis, because as you know, the standards are looking at the whole journey of sepsis, but in the front end of sepsis, which is recognising it and treating it, we've developed, along with many stakeholders, a pathway. So a screening and recognition tool, which is a clinician decision support tool that helps your more junior staff on the basis of observations and histories to get more senior staff to see those patients. The tool doesn't say this child has sepsis. The tool says, this is a child with some severe features of illness. Could you get someone senior to see them quickly? And then we know from the work we've done in Queensland that our senior doctors are pretty good at spotting what is sepsis and spotting what isn't. If they say it's sepsis, then it gives them a treatment guideline for the next sort of hour to 2 hours to 3 hours of work that they need to do.
So it's calling in someone senior, but the senior person's also got to be willing to be called in. So what's your message to your senior colleagues?
We've all been caught out with sepsis in our lives. We don't want that to happen. As Carolyn says, we go to work to help sick people. We don't want to miss that case. So be open to the suggestion.
And how quick do we have to be? It's this time critical element. How quick do you have to be with a child?
Well, in children, we know that of the children who die, 50% of them will die within the first 24 hours. So that means that our window of opportunity to get in there and turn that ship around with medications and interventions is really quite short.
Look, just before I leave you, and I'll come back to you again, but I felt I heard from Carolyn a very strong message to listen to the parents, to work with the parents. Can you talk to that? What are you looking for from parents when you're trying to decide, could this be sepsis?
Sure. So most parents, as I said, childhood infection is common. Most parents will have lived through common infections with their children before. They know their children's behaviour. A lot of the initial early signs of sepsis are pretty difficult to pick up. Many of them are behavioural. So a small baby with a headache isn't going to tell you they've got a headache. They're not going to tell you that they feel awful. So it's a change in behaviour we're trying to pick up. And parents will be able to express that because they are the experts in their children. And they also know that, when they've been sick before, they haven't been sick like this. They've normally turned around in this time. This is different. There's something about this that's different. Now, me as a busy clinician, when I'm in, working away, all the children are pretty lethargic compared to what they would normally be at home. I won't be able to tell that this particular child is much more lethargic than normal. I need the parent to do that. So we're working in partnership with the parents to get that early diagnosis because the early diagnosis is key. Late sepsis and the signs of late sepsis are easy to pick up, but a lot of morbidity and mortality associated with that. We want early sepsis and that we need parents' involvement.
I'll come back for this all-important question of the follow-up after recovery, but let me welcome into our conversation Professor Simon Finfer, the intensivist from Royal North Shore Hospital and an international expert in sepsis. I guess I'd like to ask you, for the senior clinicians watching this, there's so much pressure at the moment with all that's happening in the world with COVID and everything else. What are your messages to your senior colleagues when they're called in?
Well, I think it's very important for people to realise that sepsis is the commonest cause of preventable morbidity and mortality. And as Paula has said, I think this could it be sepsis message is very, very important because generally you won't be called as a senior clinician to be said someone's got sepsis. You might be called, and again, the problem is it could be any senior clinician, that we don't have a sepsis specialist in the hospital. So if a patient comes with pneumonia, sepsis can be caused by any infection. So if a patient comes with pneumonia and is developing sepsis, they're probably being treated by a respiratory physician. If they've got a perforated bowel and they're developing sepsis, they're probably being treated by a general surgeon. And it can be almost any specialist within the hospital. So it's really important that we get this message out there that it's got to be across the whole of the healthcare system that sepsis is a preventable cause of death and disability. It has to be recognised early. As Paula has said, it's a time critical condition, which many people traditionally has not been recognised. It's relatively new that we have data that tells us that if we delay antibiotic treatment by even an hour, in someone whose blood pressure is affected by sepsis, their mortality risk is increasing by between 4 and 8% per hour of delay. So it's time critical. It's not something where you could say, look, I'm in a busy clinic, I'll come and see them in 4 hours' time when I finish my clinic. It really is a time critical medical emergency.
And from your experience working in hospitals, to get that speed of reaction, you really do need to have a lot agreed in advance. There's trauma teams, there's cancer teams. Are you looking for sepsis teams? What are you asking the health clinicians to do wherever they're working?
Well, we've made huge, you've used one good example there in trauma care, where we recognise the golden hour 30 years ago. The same with acute myocardial infarction, heart attack, the same with stroke, where we have pathways now where someone is coming to the hospital, and this starts pre-hospital. If someone's coming to the hospital with chest pain and they think there's a heart attack, there's a team of people waiting to treat them. Sepsis is much harder to diagnose, so it cannot be obvious, and that's one of the things we have to work on is the awareness. But when there is the possibility of sepsis, then it's important that there are already systems and pathways in place so the right treatment is delivered as quickly as possible.
Look, we're going to hear from Carolyn Hullock again, the emergency physician, because she's had a long-term special interest in the very old, the elderly in accident and emergency. And I'd love you to listen in, Simon, if you would, and identify the key messages we should take away. Carolyn Hullock, you're from Hunter New England Health. You work all the time in accident and emergency. Why are older people so hard to diagnose?
I think there's quite a few reasons. One is that they often have other chronic illnesses, so they may have heart failure, they may have respiratory failure. The second thing is that they're often on multiple medications. In a study we did locally, I think a person with dementia in our hospital was on an average of 10 medications. I can't even imagine how challenging that is. And the challenge with the medications is that it might impact on their vital signs. Their pulse rate might be low if they're on a beta blocker, for example. The third thing is, I think, around the consequences of aging, and sometimes their immune system doesn't respond as well to an infection. But probably the most important thing is the consequence of sepsis. Because of their vulnerability and because of their age, even a small illness may have an impact on their outcomes. So they may actually do worse than if they were a fit and healthy young person. And the important part about that is that they may never actually go home. They may end up in rehabilitation, or they may end up in a nursing home.
Carolyn, can you give me some examples of the kinds of signs and symptoms you'd be looking for, and then you're thinking, could this be sepsis?
I think that older people may respond as a younger person with sepsis. They may have a fever, they may have a tachycardia, but also they may not, and they may just have a low grade fever. They may actually have no temperature at all. They may have a low fever, but also they may be confused. And a really important part of ensuring that patients and families are together is maybe checking with their families. Is mum how she is normally? Is she confused? Is she not quite right? Because often families have a much better understanding of how that person is. So I think the difference between a younger person and an older person is that the symptoms can be much more subtle and the signs can be much more subtle, and then it's important that we think about, could it be sepsis? And as I mentioned earlier, with chronic disease, we may be thinking, oh, could this be heart failure? Could this be could this be another problem? And I think we always need to keep coming back, okay, could this be sepsis?
There's an emphasis in the new standard on calling someone senior in quickly to check if it could be sepsis. Why is that so important?
I think it's recognising that when the vital signs are abnormal, but I think, and as I said, having systems in place to make sure that you can actually call that senior person. But the reasons why we need a senior person is because it's actually a really difficult diagnosis. And if you're not sure, I would always encourage the junior doctors and nurses to ask. It's much better to ask me to come and see the person and be wrong than it is to miss a diagnosis of sepsis.
You know, even as a very experienced doctor, Carolyn, you're frightened by sepsis. Why is that?
I just think because the diagnosis is difficult, and the consequences of treating someone with sepsis and giving them, an older person, significant volumes of fluid when it's the wrong diagnosis, and that it's a different diagnosis, is challenging, and that we actually just need to be reflecting on that. And as I said, for me, the solution or the antidote to my fear is actually knowing that everyone's on the same page and that we've got a system in place so that the triage nurse, the nurse in the resuscitation bay, the junior nurses, the junior doctors, that we all know what's expected of us in managing sepsis.
What do you see as the role of the sepsis coordinator?
I think the sepsis coordinator actually has two roles. So one's about the individual and making sure they know what's going on and that all the team's informed. It's about supporting the teams in the clinical management and being the sepsis expert across the hospital. But it's also in reflecting and understanding the system that we've put in place, like auditing the charts and how long did it take us to get antibiotics in sepsis and how did we go last month. We've got an excellent sepsis coordinator in our hospital, and she presents regularly at our morbidity and mortality meeting in the ED, so that we can actually think about how we're performing in sepsis. So I think so there's two separate parts. One's the individual patient care, and then the other part is around the system. And if you don't have someone concentrating on that role, then we can miss the boat, and we don't know how we're going.
Well, Carolyn, thank you so much.
Thanks, Julie.
You know, Simon, listening to that, you just get a real sense of the challenge of recognising sepsis in accident and emergency. What are the key points there that you'd like to emphasise to help the people watching this so they get it right?
So 80% of sepsis arises in the community, so presents to the accident and emergency department. But I think we also mustn't forget that means 20% is actually arising within hospital, someone who's already in hospital for something else. And sometimes that's a bit more challenging because that's the entire hospital you need to educate rather than just one department. But the important thing, I think, is that whenever someone is acutely unwell or deteriorating, that sepsis is in the differential diagnosis. If there is no other clear cause, you do have to ask yourself this question: could it be sepsis? If someone's hit by a truck and they come in with multiple broken limbs, you're pretty clear there's another diagnosis for why they're unwell. If someone is in the ward having had surgery, and again, this can be challenging, particularly at the extremes of age, particularly in elderly and the very young. Someone's had surgery and they're deteriorating, and there's a deteriorating patient clinical care standard that should apply, that when they're approached by a team trying to work out what's wrong with this person, if there isn't some other cause, then it is quite a high likelihood that sepsis is playing a role. And there is, again, as Paula said, there's no specific test, there's no blood test, there's no X-ray, there's no tissue diagnosis for sepsis. It's being aware of the constellation of clinical signs and symptoms, and that they can be atypical and subtle, so you don't miss that time period in which you can turn it around. And we know the long-term outcomes of sepsis, up to 50% of people left with physical, cognitive, and psychological injury from sepsis. That's potentially preventable. So that's why this awareness of it and the awareness of the difficulty of the diagnosis and the complexity of the treatment. And if I am allowed a few more seconds, I have to say that I think the large group of people that worked on the clinical care standard, hundreds of people, who recognized the importance of this role of a coordinator, because someone with sepsis, if they come to the emergency department, they may go to the intensive care unit and then to a ward and then to somewhere else. And those may not occur in that order. There are multiple transitions of care, and we need to make sure that we don't drop the ball when someone moves from one team to another, that the appreciation that the person has had or has sepsis and the care they need is maintained. And that's a key role, both for pathways and systems that are set up, but also for a sepsis coordinator.
And for example, we can look to cancer with the use of coordinators there, often nurse coordinators that get all the different pieces of the hospital and even the primary care, the GP system, to talk to each other. I'm going to come back to the sepsis coordinator, but I want to bring in now Dr. Lorraine Anderson, Medical Director of the Kimberley Aboriginal Medical Services in Western Australia. And you'll remember, Lorraine, I think you're responsible for 5 remote clinics. And you've probably been listening to all of this thinking, golly, the challenges we face remotely are just amazing. Yeah. Just give us a sense of what a remote clinic looks like and who's there, and then we'll go to the work you're doing in the Kimberley to ensure that patients have a chance to be identified and survive sepsis.
Yeah, for sure. So within CAMS, or the Kimberley Aboriginal Medical Services, we have 5 remote communities that we look after from a clinical point of view. In most of those communities, we have a clinic set up which has an on-site Aboriginal health workers and remote area nurses, and some of those sites do have doctors on site. But on the whole, the doctors are actually on the phone rather than actually on site in the clinics. So we've got these clinics out there that are if a patient presents potentially with sepsis, the first person they're going to see is an Aboriginal health worker, and then with some backup from a remote area nurse.
And you've put a lot of work in the Kimberley, I know, to training and trusting your staff, but of course you deal with casualisation and agency people as well. These are the challenges of the modern health system. As I understand it, you want your staff to put sepsis at the top of their list, and that even if they have the smallest suspicion that it might be sepsis, what do you want them to do? If they have that suspicion, what do you want them to do?
I want them to phone the on-call doctor and raise the alarm. Okay,
and when you say raise the alarm, what do you mean?
Use those words. I think this could be sepsis. I think that is absolutely vital. There is nothing that that will raise the senses for a doctor than those words. I think this could be sepsis, and it really brings in that need for the doctor to actually be awake, be on the ball, and start working through the process of how to deal with this.
And evacuation, can you explain for the more urban viewers just what is involved in evacuating someone? Because you can't deal with sepsis, can you, at the local clinic level?
That's right. So we can certainly deal with the first couple of hours, and in particular with getting the suspicion of the diagnosis and also starting fluids and antibiotics. For sure, we can do that. But the ongoing care of that patient needs a bigger hospital, and evacuation out of our clinics, our remote clinics. One of our clinics is well over 1,000 kilometres from our big hospital in Broome. So coordinating that evacuation is actually quite a mission.
You want someone ringing the doctor while the other person is observing the patient, don't you?
That's
phone
right.
call to the doctor is critical.
Absolutely critical.
And you've done a lot of work to have all the information and things that you need in one location. Now, I gather in some remote clinics there are birthing boxes. You're talking about a sepsis box. It may not be a literal box, but tell us some of the strategies you're advocating so that your teams can move quickly.
Absolutely. So one of the things that we need to remember is that in a remote clinic, you could have anything walk through the door, and we need to have our staff in a position where they can put their hands on the information that they need immediately. And so in terms of when we talk about a sepsis box, it may be a sepsis flow chart, and that might be on the wall, it might be on the resuscitation trolley. It's going to be somewhere where they can go, I think this is sepsis. They can get the resource that they need, and they can start following the process really quickly.
And give us a sense of how many posters you've got on the wall, so we get a sense of how much priority you're putting on sepsis in remote Aboriginal communities.
So on the wall in the little emergency room in each of our clinics, we have the acute life support process. We have a process around anaphylaxis, which is allergies, and now a process around sepsis.
So it's that important. We've already heard in the paediatric or child context the importance of talking to the family. Does the child seem different? Talking to the family is important in communities as well. Can you explain that a bit?
Absolutely. So our staff in our clinics know the families in the community really well, but we can't get past the fact, and Paula mentioned this when she was speaking, we can't get past the fact that the families know their own family better than anybody. So we really need to get that message across to our clinicians that if the family are concerned about the patient, we really need to take that on board.
Yes, it's so interesting. Let's move now as a group to this question of if people survive, the very large number of people, and adults and children, who may have very significant physical, psychological and cognitive impacts, because I think that will be news to many Australians. I'll stay in remote communities, if I may, in Western Australia. Your plea to everybody listening to this, wherever you're working with Aboriginal people, is if you're discharging people back to communities, tell us you're discharging people. Explain why that's important.
Look, it's absolutely vital, and I can't express this enough that when you're asking a patient who lives in a remote community who their GP is, they'll often not. That won't resonate with them. You need to be asking, which clinic do you go to? Where do you want your information sent? And that information comes back to that remote clinic, and that clinic will be prepared for that patient to be returning to the community. And they'll then be able to follow them up, make sure that they get the best possible aftercare, and make sure they're on a care plan around potential post-sepsis.
And this post-sepsis syndrome, I don't know how familiar that is to a lot of people. You've had a bit of experience with this in remote communities, haven't you?
We have. You know, the thing with post-sepsis syndrome is that often it's not recognised early enough, and often what we see is that it's a retrospective diagnosis. You know, you see someone who's got symptoms that keep carrying on, and retrospectively we're making that diagnosis of potential post-sepsis syndrome.
Look, just before I come to our other colleagues about post-sepsis syndrome and its aftercare, and I just want to ask you for a general comment for people who are working with First Nations patients, Aboriginal and Torres Strait Islander patients anywhere in Australia. You think it's critical, if you think it's sepsis, to let them, and if they have a family or companion with them, let them know this is serious, you need to stay. Why is that important?
Absolutely. I think across the board that it's really important that we communicate with our patients very clearly the significance of the potential diagnosis of sepsis, because people will get sick of waiting while we're all fluffing around making phone calls and taking blood, and people get sick of waiting. And if they don't understand the gravity of the situation right up front, there's potential that we'll lose them.
Look, I'll come to Associate Professor Paula Lister again from Queensland, working with children. Again, this emphasis on the communication with family. Just before we go to post-sepsis syndrome, do we need more community education of the population generally so that family can be partners in care?
Absolutely. And probably Simon can talk even more to this, because the George Institute did a survey of public awareness of sepsis, and it's pretty abysmal. And certainly the age group among adults with the least amount of knowledge of sepsis are those of sort of parenting age, sort of 20 to 40s. And they, you know, many people didn't know what sepsis was, and B, even if they knew what it was, couldn't name a sign or symptom other than fever. So that's pretty scary if you have a child at home who's doing something that you haven't seen before, because you wouldn't necessarily know that it meant it was sepsis.
And I think the Commission's going to be doing a lot more work in the future in that community education. But let's come now to, you know, what are the key long-term impact of sepsis issues for children? Because I think this is an area many in the clinical community don't realise is a major area of concern.
Well, I think if we're honest, Julie, we don't know yet. We certainly are aware of this, that those children who suffered severe consequences, you know, whether it's limb loss or severe neurological impairment. But we're only starting to find out that even kids that we thought had a pretty uncomplicated course in intensive care, they're having behavioural issues and issues at school that last years. And when you think about children who maybe have sepsis under the age of 5, who are going to be educated members of our community's tax-paying individuals for the next 50, 70 years, we really need to be paying attention to what the long-term cognitive effects are of sepsis and behavioural effects are. It also has an effect on the family dynamics and parent-children and parent-sibling interactions that we're finding that we need to investigate.
But Paula, as I understand it, the standard is advocating that there is a sepsis coordinator and that part of that role is the aftercare coordination, but that you want multidisciplinary team involvement and clinical care pathways that are established for sepsis. Tell us a bit more about what you're actually doing where you are to carry out that philosophy.
Well, in Queensland, because we're working very closely with consumers and clinicians to develop a post-sepsis model of care that's going to work for remote areas as well as regional areas, and hopefully we will have something that's fit for a piloting at the end of the year. But I think it's really important to hear the consumer's voice in this, and what we've heard from consumers in the research we've done is just how isolating it is to have a child with sepsis, just how you want somebody who's lived this journey as well to give you some support. And so we've actually now also started a peer support program where families or parents who have had a child with sepsis go through some training, are supported by advanced social workers in their role, and they will then mentor families who are acutely going through it and then into their post-sepsis, because we've heard that that's what they want.
And you're doing research, is that right, into the psychosocial impact? If you could just explain what those words mean and what that research is that you're doing.
So it's not me in particular, but it's partners that we're working with. We're looking at the impacts on education and educational long-term outcomes, and hopefully that will be published soon. But it does look like children who've had sepsis under the age of 5 are not doing quite so well in their NAPLANs. To a significant degree.
And NAPLAN is an educational test that tells a child where they're placed educationally compared to everybody else in the country.
As in they're not being put forward to sit those exams to a significant degree. So we are gathering more and more information that the more subtle signs are there in probably more children than we thought who survive sepsis.
Simon Finford, do you think that many people realise that so many people are affected, not just with these physical disabilities, but cognitive and psychological disabilities? Is this well known in the health sector, long-term impacts?
Unfortunately not. So, as we said, there are physical, there are cognitive, there are psychological issues following sepsis. The physical ones, when people have lost limbs, they are very obvious. And while systems are not perfect, at least that is recognised, and there are pathways to care. The psychological and the cognitive impairment is harder to understand and pick up. And I would say in the Australian Sepsis Network, we have an email button on our website where people can click on it and send us messages. And one of the commonest questions that we get is, I've had sepsis, I've been discharged from hospital, I'm not right, I can't work, I can't look after my children, I'm scared I'm going to lose my job, I can't think the way I used to be able to think. I've read about this post-sepsis syndrome by Googling or on your website. I've been to my GP and they tell me they've never heard of it and they don't know what to do about it. It's in terms of the information gathering about post-sepsis syndrome is relatively new. It's the last 5 to 10 years, because when I started doing intensive care, people with severe sepsis didn't survive. It was like 80% mortality rate. So the number of survivors was relatively small. We have been very successful in reducing mortality through some awareness. We've still got a way to go. And we've now got the mortality rate for people who end up in intensive care with sepsis down to the high 20%, which is still too high, but it means you've got 70+% surviving. So there's that much bigger burden for the survivors, their families, the healthcare system, finances. So the information is evolving, and again, an important role for a sepsis coordinator will be someone, I think, that patients can come back to and say, I'm just not getting the help I need, and then put them in touch with the right people, whether it's psychologists, psychiatrists, rehabilitation physicians, whatever. And none of those groups, there's no organised pathway, and that's one of the things the sepsis clinical care standard is looking to do. Like we have for stroke, heart attack and other things, we need an organised pathway and rehabilitation system.
Look, if I could just say, as a survivor of cancer, I had 5 years of highly coordinated multidisciplinary care. It's as simple as that. And I guess that's what we're looking for in the post-sepsis experience. Coordinated multidisciplinary care. And I'd just like to acknowledge that in the people who contacted us on registration for this webinar, 2 key themes came through. One was the challenge of caring for people who may have sepsis in remote communities, not just Aboriginal communities, but generally in remote communities. But the others were parents expressing a kind of despair at how little the knowledge base seemed to be about sepsis among some clinicians. But could I just emphasise that in the materials that the Australian Commission on Quality and Safety is preparing on sepsis, they're going to have a discharge planning guide for patients with sepsis and also a template of a letter to general practitioners. Perhaps I could come back to you, Paula. How well are we going on that connection to primary care, to community care after discharge?
At the moment, it's pretty dire, and that's what we've heard from our consumers. So many clinicians, particularly in remote areas, won't have a primary GP. And if they do, as Simon said, many primary GPs will not have heard of post-sepsis because it is something that is evolving in the last sort of 5-10 years. So the role of the coordinator is key in not just coordinating and making sure those multidisciplinary team meetings happen before the child or patient is discharged, but that connection is made back to the GP so that continued coordination of care and access to specialised services carries on. And that's particularly important for children where a lot of specialised services is centralised in key hospitals. You know, in Queensland, it's one hospital. In Western Australia, it's one hospital. So you actually need to get those services out. And our post-sepsis model of care will be using those coordinator roles to ensure that dispersal and that information is got out.
As concisely as you can, you know how burdened your colleagues are, multidisciplinary colleagues are. Why should they look at this clinical care standard on sepsis and take the time to really engage, in a nutshell?
In terms of post-sepsis care, it's because we're not reinventing the wheel. We are making use of what is existing already and to streamline that and to make access for our parents and patients easier so they get what they need, so they're not stumbling in the dark. But we're not asking to reinvent the wheel at all, just streamline.
Yes, we'll be giving materials to people. Look, I just want to thank our panel. I want to thank Associate Professor Paula Lister from Queensland, where she works with children, Professor Simon Finfer, AO, an intensivist at Royal North Shore in Sydney, but you seem to work across the globe on sepsis. And thank you so much to Dr. Lorraine Anderson, Medical Director of the Kimberley Aboriginal Medical Services in Western Australia. Look, we're now going to have the official launch of the Sepsis Clinical Care Standard, and it's my pleasure to introduce the Chair of the Board of the Australian Commission on Safety and Quality in Healthcare, Professor Phyllis Marshall, AC.
As Chair of the Board of the Australian Commission on Safety and Quality in Healthcare, I would like to thank you all for joining us today. I'm very pleased to officially launch the Sepsis Clinical Care Standard. The World Health Organization has recognised sepsis as a key global health issue. If not recognised early and managed promptly, it can lead to septic shock, multiple organ failure and death. It is most frequently a serious complication of infection. Through the National Sepsis Program, the Commission is bringing a national focus to the care of sepsis in partnership with the George Institute for Global Health. Early treatment is essential for optimal care, with time-critical interventions having a significant impact on the risk of death and poor outcomes. This new national standard will ensure that a patient presenting with signs and symptoms receives timely recognition of sepsis, early and appropriate antimicrobial therapy, and continuity of care from the acute setting through to the discharge and survivorship. Sepsis can occur in any healthcare setting, so as a healthcare community, we need protocols and pathways that allow us to act quickly. We need to coordinate care and have a clear communication along the healthcare pathway, especially at transition of care, including hospital discharge after sepsis. I would like to thank all the clinicians and consumers who have contributed to the development of this important standard, especially our panel members. Their expertise and experience have been invaluable. I hope that you have enjoyed this webcast and find the resources useful and relevant. Thank you again for joining us today.
And I'd like to thank you so much, Professor Villiers Marshall AC, for that launch. Well, look, let me close with 3 messages. I feel like asking you, what are your 3 key messages? But here's 3 I want you to remember. Recognise that sepsis is complex and difficult to recognise, and ask yourself, could it be sepsis? Put in place systems to manage sepsis, including a sepsis coordinator and a sepsis pathway. And recognise the long-term impacts of sepsis and put in place multidisciplinary, coordinated care for people who are recovering from sepsis. And of course, we have lots more information for you on the new Sepsis Clinical Care Standard. Go to www.safetyanquality.gov.au/sepsis-CCS. There you're going to find fact sheets, and these are for people with sepsis and their families, and also for parents and carers of children who've had sepsis. There's resources also to support clinicians and healthcare services to implement the sepsis standard, and there's lots of educational resources. There are case studies and podcasts, and of course there'll be a recording of this webcast, and there'll be more to come in the coming months. So please tell your colleagues about this webinar, share it widely. My name's Julie McCrossan, and I just want to thank you so much for joining us. Goodbye.